President and CEO of Arrowhead Research Corporation. Yes, and he will speak about novel hepatitis B treatment. Please.
Great, thank you very much. It's a pleasure to be here. Thank you for having me today. I have to show you this first. The lawyers require us to show this. We are a publicly traded company, and so this essentially says, don't believe anything I say. Go back and look at our SEC filings. Okay, so we are Arrowhead Research Corporation. We are about an $850 million or so company. We're traded on NASDAQ, and we have recently raised a substantial amount of money, so we are able to push all of our programs forward by ourselves. At this point, we have about $180 million of cash. So we are a targeted RNAi therapeutics company. We acquired Roche's RNAi business about 2.5 years ago, and what that enabled us to do is to be really a complete RNAi company. We have core competencies both in RNAi delivery as well as in RNAi chemistry. Now, the importance of both of these is the following. So the RNAi chemistry, we've got broad freedom to operate across multiple siRNA triggers. These include mirror-duplexes, dicer substrates, canonical structures, UNAs, and the like. That's important because what we found is that depending upon the target, some of those structures are more or less efficient than others. And so we are able to optimize our RNAi chemistry on a target-by-target basis. Now, of course, delivery has been a great unmet need for RNAi, and that's where I think our core value lies. We have a delivery system that is efficient, it is targetable, and it is well tolerated. We are in the clinic right now, which we'll talk about in a bit. And it is what we think to be the most potent delivery system and leads to the most significant knockdown that the industry has shown to date. We have a lead program in hepatitis B, which we will be talking about today, and we are in a phase 2A in that program. I wonder if I separate these, I can help that with that. So this is our pipeline. Our lead program here is ARC-520. It's against chronic hepatitis B infections. We are in a phase 2A program there. That is our key value driver, at least in the near term, I think. However, long term, we view our platform as a substantial value driver. Underneath hepatitis B, we have a new program that we just announced, in fact, last week, against liver disease associated with alpha-1 antitrypsin deficiency. We will file an IND in that program by the end of this year, and then we have several programs underneath that, both within the liver as well as extrahepatically, and we have not disclosed what those targets are. We think HBV is a great first target for a lot of reasons, not the least of which is that it is a substantial unmet medical need. There is no cure for hepatitis B right now, and we think we might have one. And so how do we do it? Well, this is our delivery system. We call them DPCs, or dynamic polyconjugates. Don't think of it as a specific delivery vehicle, but think of it as a delivery system. We have a library of polymers that we can use, and the common denominator among all the polymers is that first they are targetable, shown here in the orange balls. That enables us to get into cells via a receptor-mediated process, and also all of our polymers have amine groups up and down the backbone. The importance of that is that enables us to get out of the endosome once we get into a cell. So those amine groups are masked via proprietary masking chemistries, and so while they're in circulation, these are essentially neutrally charged. Once they get into a cell via, again, a receptor-mediated process, they are encapsulated into endosomes, and at that point, those endosomes mature and acidify, and with that acidification, the masking chemistries fall off, exposing the amine groups, and that then lyses the endosomes and enables the siRNA to get into the cytoplasm where it can do its job. Our scientists, I think, discovered a long time ago that siRNA delivery is really a two-step challenge. One is getting the siRNA to the right cell at the right time. But second, once you're in the cell, getting it in the right cellular compartments. Once siRNA gets into a cell, it wants to be encapsulated into an endosome where it'll be degraded, and so we needed to find a way to get those out of the endosome quickly and efficiently, and we've done that. And it is for that reason, I think, that we are able to get such deep and durable gene knockdown. So hepatitis B, again, is our first program. It is the world's most common serious liver infection. There are somewhere between 350 and 400 million chronic infections worldwide. That's 1 in 20 people on the planet. So it is a substantial need. About a third of these patients will end up having liver damage, either cirrhosis or hepatocellular carcinoma. And in fact, HBV is responsible for about 80% of primary liver cancer. And again, as I mentioned, there is no cure. So our goal here is to provide that functional cure. And we think if we can do that, we can really make great strides from a public health standpoint. So let's take a couple of minutes and look at the biology of HBV. It's important as it relates to our mechanism of action here. So shown here in the left panel, if untreated, a virion will get into an hepatocyte, and it will do two things. It will create new virus, like any virus, and it will also create large quantities of viral antigens, a variety of viral antigens. One called surface antigen or S antigen, E antigen, X antigen, a number of them. It's thought to be, though, that the most important of these are the S antigen or surface antigen. That makes up part of the capsid, and it's thought that it is that free S antigen, again, in much higher quantities than fully formed virus. It is that free S antigen that immunosuppresses the host and keeps that host from clearing the virus. So it has been the holy grail of HBV research to find a way to knock down, to reduce that S antigen. It's thought that if you can do that, you can enable the immune system to come up naturally and clear the virus. So that's what happens if untreated. The current real standard of care, at least in the United States, is with nucleotide or nucleoside analogs. Entecavir and tenofovir are probably the two most well-known and probably the two best. One is a Bristol-Myers Squibb product, and one is Gilead. And those do a very good job of blocking one of these two pathways. They do a great job of blocking the production of new virus. If somebody takes a pill a day for the rest of their life, they can have virtually or even undetectable levels of circulating DNA, viral DNA. However, these do nothing for the S antigen, and so these do nothing for getting to this functional cure. The patient still has, still has HBV, and if they go off drug, their titers of virus will go right back up. So these are great therapies for keeping a host from being from infecting his or her partner, but again, they don't provide a cure. So we thought that RNAi was tailor-made for HBV. Because if we can get the right sequences into the cell at the right time, we could silence the entire HBV genome. And if you do that, you could block both these two pathways. You could block the production of new virus, and most importantly, you can block the production of these free S antigens. If you could do that, you would enable the immune system to come up and clear the virus. That has been, again, the holy grail of HBV research, and people have been trying for years to reduce circulating levels of S antigen to no avail. And again, we thought that RNAi was a potentially very powerful way of doing this. So, does it work? The answer is we think it does. We started with 140 sequences that we developed in silico, and interrogated all of them in vitro and found that some were quite effective and some were less so. We took the 4 most effective and went into animal studies, and of those 4, we took 2 to go into the drug ARC-520. The importance of 2 sequences versus 1 sequence is the following. First, it enables us to guard against mutations it is more difficult to mutate around 2 sequences than it is to mutate around 1 sequence, and so it can help us against resistance. Most importantly, however, there are multiple genotypes of HBV, and so with 2 sequences, we cover, we think, the primary genotypes. I think there's about 10, and we cover those. GeneBank is a repository of about 2,400 or 2,700 sequences of HBV, and we cover 99.6% of those. And so we get pan-genotypic coverage, at least in theory, with these 2 sequences. We then took these into animal studies and first looked at a non-transgenic model, and what we saw was stunning and was a first in the field. We saw deep and durable S antigen knockdown, 3 and 4 logs of knockdown very quickly, and that lasted several weeks. We saw deep and durable DNA knockdown, again, 3 and 4 logs of knockdown. No one had ever shown that quick knockdown of DNA. Again, the nukes do a very good job of knocking down DNA over time, but not this quickly. the nukes do, of course, nothing for S antigen knockdown. And we saw E antigen knockdown to the level of detection. So this is very exciting. Again, this was a first in the field, and more broadly, no one had ever shown this level of knockdown in RNAi for any target. This is a world that used to get excited about 60% reduction and then 80% reduction and then sometimes 90% reduction. And what we're showing is 99.99% reduction. So it was a very, very potent delivery system that we showed. We then did this in a transgenic model and saw very similar results. So with that, we were excited and prepared to move into the clinic and initiated GLP tox studies to do that. And about this time, we came across a chimpanzee with chronic hepatitis B infection. So chimps get HBV the same as humans do, and it's the same virus. In fact, the chimp that we studied was a B genotype of HBV. And of course, physiologically, chimps are quite similar to humans, and so it was going to be a very good model for us. And also, chimps were used for the development of the vaccines, and they proved to be quite predictive of human outcomes. And so we were excited to be able to study this animal. We could not go for curative intent. We were not able to study the animal for a long period of time, and it's thought that you really need to keep S antigen knocked down for several months in order to get a functional cure. But we were able to study this just to verify what we saw in the rodent models. So that's all the good news. The bad news was, it turns out this animal was extremely viremic and antigenemic, much more so than we'd expect to see in humans, maybe 3 or 4 orders of magnitude higher titers of circulating DNA than we'll ever see in humans. Excuse me. So that was going to be a very high bar, a very difficult subject to show deep knockdown of S antigen or of DNA. Potentially even more importantly, it turns out, just by dumb luck, this animal was a mismatch for one of our 2 sequences. And so she had a mutant form of the virus that was mismatched for one of our 2 sequences. And so this made us feel smart in that it validated the reason to have 2 sequences, but it also meant that maybe half of our drug was going to be ineffective in this animal. Even so, we went forward and tested her and just recognized this is probably the worst case scenario for us. And what we saw, I think, was truly stunning. We saw about a 95% reduction after short exposure to the drug of DNA, of circulating viral DNA. We saw about 95% reduction of circulating levels of E antigen and about 85% reduction of circulating levels of S antigen. No one had ever shown that before, and so we were thrilled by that. We showed this in a safe environment. We didn't see any signs of toxicity whatsoever. And so if that's all we saw, we would have been thrilled. But what we also saw was evidence that we de-repressed our immune system. So shown here, let's see here. There we go. So shown here, this is shown here in the shading here is ALT increases. Now, what we saw was at the nadir of S antigen knockdown, so this is S antigen, it came down about 85%. At its lowest level, we then saw an increase in circulating ALTs. We knew that was not a result of direct toxicity of the drug, because when we're at a toxic dose, we do see ALT increases, but it is within 24 or so hours of administration. You know, the delivery system, which is the driver of tox, is cleared very quickly. What we use, the DPC that we use for HBV is a polymer. I'm sorry, it's a peptide. It's a natural L-amino acid peptide, so it's broken down quite quickly. So we were comfortable that this was not a result of tox. And also, this was consistent with certain cytokines and chemokine upregulation that we discovered via biopsy that would indicate, to us at least, an immune reactivation. And so we were thrilled. You know, we saw the first steps in a cascade of events that should lead to a functional cure. Now, it was tantalizing because we were not able to keep this animal on drug and keep S antigen knocked down for a long period of time to really enable the immune system to clear the virus. But we saw those first steps. And again, we think this was the first time this has been ever shown, and we were thrilled by this. So on the basis of this, we then moved into the clinic. We started a phase 1 study in Australia in the fall of last year. No, I'm sorry, in July of last year. We finished it in the fall of last year. We had 6 cohorts, 4 patients on drugs, 2 placebo, over 6 different dose levels. It was a single dose study, and it was a clean study. we saw no signs of end organ toxicity whatsoever, no BUN increases, no creatinine, no ALTs. We saw no difference in frequency or severity of AEs between placebo group and drug group. And so we were happy to move into a phase 2A, which will be in chronically infected patients. That study started in March of this year in Hong Kong. We're studying 2 different dose levels, single dose study. We're studying 1 mg per kg and 2 mg per kg. We finished dosing the first cohort quite quickly. We have not discussed follow-on cohort, but we finished that very quickly. We have 2 sites up and running in Hong Kong, and our endpoint there is depth and duration of S antigen knockdown. So the 2A will inform the 2B in that we want to see in humans how deep and how durable the S knockdown is, and then based on those data, we'll move into a multi-dose phase 2B study where we will look to keep S antigen knockdown for some period of time to get to that functional cure. We have said that while the plan in the phase 2A is to dose at 1 mg per kg and 2 mg per kg, we've also said that we're happy to move to 3 mg per kg if 2 mg per kg does not give us the level of knockdown that we want, and that level is probably about a log in knockdown. It's difficult to say what is required to get to functional cure because we are, for good or for bad, pioneers in this space, and it's not really known how deep you have to knock down. But interferon studies suggest that somewhere in the half log to a log range is where you kind of want to be. So this is ongoing. We have said that we'll have phase 2A data next quarter, and we are excited to present that once that is completed. And then again, we will start a phase 2B probably in the 4th quarter of this year, which will be a multi-dose study where the endpoints really will be to find functional cures. That'll be a multinational study. The importance of that is not just numbers, but also we want to get a broad coverage of genotypes, and so we'll have Asian sites, we'll have U.S. sites, we'll have European sites, so we think that we'll start to see functional cures sometime in 2015. So we have a lot going on at Arrowhead. This is again our key value driver, but we also have a new program against liver disease associated with alpha-1 antitrypsin deficiency that will hit IND at the end of this year, and then that will be in the clinic next year. We think we'll have clinical proof of concept for that next year. We think that we may also have clinical proof of concept for the HBV ARC-520 next year as well, and then we'll have at least 1 new candidate in the clinic next year and potentially more. And so with that, I'm happy to take any questions.
Thank you very much.
Sure.
For this interesting talk. We have questions? Yeah, please. Please wait on the microphone.
Hello?
No, it works.
Now it's working. Hello. Thanks for this really interesting talk. I have 3 questions actually about your targeting strategy. First one is, what is your ligand you use for the targeting? The second is, do you know something about the receptor expression in different HBV patients? And the third one is, what do you know about the accessibility of the receptor when you have a high amount of fibrosis or cirrhosis in HBV patients?
I can answer the first, I can't answer the second 2. We are using N-acetylgalactosamine as our targeting ligand. It's a really great way to get into hepatocytes. These are the receptors for NAG are highly expressed and turned over very quickly, and so it's been a really great conduit into hepatocytes. In fact, Alnylam is using the same strategy to get into hepatocytes. Regarding expression of this in HBV broadly and even more narrowly across different genotypes, I don't believe that's known. There's no theoretical reason that it would be substantially different than in healthy volunteer or healthy patients or healthy individuals, but there's no data on that I'm aware of. Regarding the accessibility in cirrhotic patients, that's a great question. We don't know the answer to that. The phase 2A is in patients without cirrhosis. The phase 2B, at least the first part of that, will be as well, and so we won't get that question probably until later in the study. We anticipate doing a number of phase 2s, to be honest. I think Pharmasset did a great job in their hepatitis C studies by doing a number of smaller phase 2 studies, and I think we'll do the same, and it may be that we'll have some groups in cirrhotic patients. I assume they're going to be more difficult to get to, but we just don't know how much.
after the session.
Thank you.
The end of the session, not after the end of the session. So now I'd like with this to come to our next talk.